dear committee, dear guests, dear colleagues, dear audience, it's a pleasure to introduce Dr. Balázs, my PhD student. He was born in 1995, and he's a dedicated medical professional with a specialized focus on cervical pathology and women's health. He completed his early education at Modács Imre High School and pursued medical studies at the prestigious Semmelweis University, earning his medical degree from the Faculty of Medicine in 2020. During his studies, Dr. Hamar was selected for the Kerpel Fronius Ödön program for talented students, demonstrating his academic excellence and commitment to research. His dissertation titled Modern Cervical Cancer Screening and Prevention, Correlation between Patients' HPV Screening Result and Cytological Findings. It was awarded an excellent grade under my supervision. Since 2021, Dr. Hamar has been pursuing doctoral studies at the Károly Rácz Conservative Medicine Doctoral School, part of the Semmelweis University's Translational Medicine Center. His research focuses on cervical pathology and the connections between clinical factors and health outcomes, continuing under the guidance of mine. His scholarly work has already made a significant impact, contributing to 2 major publications in high-profile journals. The first study published in Cancers in this year in a systematic review and meta-analysis demonstrating the effectiveness of imiquimod in reducing cervical intraepithelial neoplasia. His second publication in the International Journal of Gynecology and Obstetrics highlights an increased risk of cervical carcinogenesis associated with Trichomonas vaginalis infection. In addition to his research activities, Dr. Hamar has worked as a resident doctor at the Department of Obstetrics and Gynecology at Semmelweis University since 2020. He is actively involved in international conferences, having presented his work at various scientific events, including IZIDOG Budapest, IZIDOG Athens, and the Hungarian Gynecologic Scientific Society, Hungary. Balázs is a great sport fan. He's used to be a professional fencer. And he's proficient in English, holding the B2 complex language certificate, which supports his ability to engage in academic discussions and present research and international forums. His passion for clinical practice, combined with his research expertise, positions him as promising professional in the field of gynecology and cervical pathology. Thank you.
Dear committee, dear audience, dear everybody, I would like to present my PhD topic, cervical pathology and connection with health and clinical factors. This is my PhD defense. I would like to introduce myself. I'm Balázs Hamar. I'm a resident doctor at the Department of Obstetrics and Gynecology. My supervisor is Zsolt Melzer. My scientific methodological supervisor is Brigitte Deutsch. My vision is that primary HPV detection-based cervical cancer screening should be implemented in Hungary in the next 5 years in the above 30 years age group. And my mission is to change the Hungarian guideline on cervical cancer screening. During my PhD course, I had 2 specific projects. The first was called Trichomonas vaginalis infection is associated with increased risk of cervical carcinogenesis. Now, to give you some background, the lifetime prevalence of HPV is around 80%. This is necessary but not sufficient for the development of cervical cancer. Besides HPV infections, other risk factors are also needed, such as smoking, young age, multiple pregnancies, which are also risk factors. Trichomonas vaginalis infection causes inflammation and decreases protective barriers of the vagina and the cervix. This inflammation of the cervix might cause persistent HPV infection and in a progress in cervical carcinogenesis. And our aim was to assess the effect of Trichomonas vaginalis infection on the increased risk of cervical carcinogenesis. We had a clinical question whether Trichomonas vaginalis infection increases the risk of cervical carcinogenesis. The first population were sexually active women. We looked for TB infection, and we were curious about HPV infection, cytology, and histology results. In the second population, we looked for HPV-infected women. We once again looked for TB infections, and we looked for cytology and histology results. And our hypothesis was that Trichomonas vaginalis infection increases the risk of cervical carcinogenesis. We performed our systematic search nearly 3 years ago, and after all, we found 29 eligible articles for our analysis. Now, I would like to show you the results of this analysis. First, this forest plot shows that Trichomonas vaginalis infection is associated with HPV co-infection. Now I will show cytological aberrations, and once more, Trichomonas vaginalis infection is associated with ASCUS. So women who were diagnosed with Trichomonas vaginalis had an increased odds for a concomitant diagnosis of ASCUS. ASCUS is a low-grade cervical dysplasia. Now, moving on to the precancerous state, women who were Trichomonas vaginalis infected had an increased odds for the concomitant diagnosis for high-grade squamous intraepithelial lesion, which is a truly precancerous state of the cervix. Now, about cervical cancer, women who were diagnosed with Trichomonas vaginalis had an increased odds for the concomitant diagnosis of cervical cancer. And now this is our second clinical question, and we can see that women who were HPV positive and also Trichomonas positive had an increased risk for the concomitant diagnosis of low-grade squamous intraepithelial lesion, high-grade squamous intraepithelial lesion, and cervical cancer. To summarize our findings, this was the first meta-analysis that investigated TB infection and HPV infection and different kind of cervical lesions. It had a huge sample size, nearly 500,000 women's data. It's globally quite representative articles all around from the world. We have some limitations to confess. We found mostly cross-sectional studies, and sometimes we didn't have enough control on the confounding factors, which is important when we are talking about a multifactorial disease. And in a few cases, we experienced high heterogeneity. Some of the conclusions are that the detection of HPV infection and cervical intraepithelial neoplasia is increased in the Trichomonas vaginalis infected population. Although in the subgroup analysis, there were big differences in the odds ratios, because of the different kind of analytical methods to detect Trichomonas. The highest odds ratio was with PCR and wet mount, which are the most sensitive ones. And once again, we had a high prevalence of Trichomonas infection in the developing areas and countries. To summarize, we strongly suggest also screening and treating Trichomonas vaginalis in case of a diagnosis of an HPV infection. And longitudinal studies are needed, especially examining whether treatment of Trichomonas vaginalis reduces the risk of cervical cancer. And jumping to my second topic, which is titled Imiquimod is effective in reducing cervical intraepithelial neoplasia, a systematic review and a meta-analysis. So once again, some background. Guidelines usually recommend surgical therapy for cervical high-grade squamous intraepithelial lesion, although cervical conization increases the risk of premature birth and cervical incompetence. Topical Imiquimod is an immune response modifier drug and approved for genital warts, basal cell cancer, and actinic keratosis. In one study, Imiquimod fastens HPV clearance by 60%. And our aim was to assess the effectivity and safety of topical Imiquimod in the cervical intraepithelial neoplasia patients. So once again, the clinical question was whether topical Imiquimod is usable in cervical intraepithelial neoplasia patients. We used two frameworks, mainly because in many studies we didn't have a comparator. Therefore, we used the COCOPO framework in the first clinical question. we looked for women who had cervical intraepithelial neoplasia and/or HPV positivity, and we looked for the treatment or the usage of topical imiquimod, and we were curious about the SYN regression and HPV clearance and also the adverse events. In the second clinical question is quite the same, but we had a comparator, so that was for the standard care. And our hypothesis was that imiquimod therapy is effective on reducing cervical intraepithelial neoplasia and on HPV clearance. So 2 years ago, we performed our systematic search, and after all, we found 8 eligible articles. So I would like to show you the results of this analysis. This plot shows that this is the regression rate after imiquimod usage in SYN 2 and 3 patients, and we can see that the response rate, so the regression rate was 61% after imiquimod use. Now this plot shows that this is a comparison between imiquimod and conization, and women who were treated with conization had a higher success rate compared to imiquimod, 38% more. And so, yes, and this forest plot shows that women who were treated with imiquimod had a 50% HPV clearance rate after the therapy. And this last graph shows the adverse events. The most common were flu-like symptoms and myalgia. So some of the conclusions are: imiquimod is effective on reducing SYN, although not dose-dependently. Imiquimod fastens HPV clearance. The milder the lesion was, the higher the HPV clearance was. Imiquimod is inferior to conization, and side effects actually quite common, but although mostly mild and could be lower with NSAIDs. And to summarize, this was the first meta-analysis that investigated this question. We found positive results. The side effects were mostly mild. The limitations, once again, that we had a relatively low sample size. Sometimes the heterogeneity was high, and we had a short follow-up time. So to summarize, implication for practice is that imiquimod can be a good choice of drug in women who have future pregnancy desires, especially after conization. If the margins are positive, imiquimod use could lower the need for reconization, and also it's considerable for low-grade cervical intraepithelial neoplasia because of the high psychological burden of SYN and due to the observational time. One of the important messages of our finding is that not all patients respond to imiquimod, but the immune microenvironment is a predictive factor for treatment effectiveness, and therefore we could select the patients who can respond to this drug, so it can give a personalized therapy option. Implication for research that further observational studies are needed in the field to understand better how imiquimod can reduce the burden of cervical dysplasia and find the optimal dose of imiquimod where still effective and the side effects are the lowest. Hopefully, I mean not hopefully, luckily, two of the studies have been already published in prestigious journals. One of them in the Journal of Gynecology and Obstetrics, the second in Cancers. And for my PhD thesis, I used 2 of my publications. And as my supervisor mentioned earlier, I had the opportunity to hold conference. I had to hold presentation on prestigious conferences. 2 of them were international, and one was a Hungarian conference. And now this is the opportunity to thank and the people who supported me. Firstly, I want to thank my supervisor, Zsolt Meltzer, for the relentless help throughout the years. I want to help the head of our department, Nándor Ács, And of course, I want to thank the Center for Translational Medicine colleagues, especially my SMS Brigitte Teutsch, who cannot be here today. And I want to thank the head of the Department of Center for Translational Medicine, Péter Hegyi. And I would like to close my presentation with the words of Miro. The work must be conceived with fire in the soul, but executed with clinical coolness. Thank you very much.
Thank you, Balázs. This was really an elegant presentation and impressive results. It's open for discussion. Would you mind to start?
Thank you. So the thesis of Mr. Balázs Hamar was concluded with several important scientific and practical findings. It shows that Trichomonas vaginalis infection may increase the odd risk for cervical intraepithelial lesion progression to cervical cancer. And in cases of TV diagnosis, clinicians should evaluate not only classical sexual transmitted disease like chlamydia, mycoplasma, ureaplasma, bacterial vaginosis, HIV, and Lewis, but also they should screen for HPV and cervical dysplasia by applying dual screening, HPV DNA and cytology. I liked also the aphorism of Deci that I didn't know. TV can carry HPV as a Trojan horse. Congratulations. So TV is a surrogate marker for high-risk HPV infection. The question is, why did you choose TV and not, for example, bacterial vaginosis? And if you know which is the incidence of TV infection in Hungary, for example, in Romania, of course, like usual, we don't have official data, but the general impressions among gynecologists is that Trichomonas infection is decreasing now in comparison with 10 years ago. I can't say the same about Candida infection or bacterial vaginosis, which are on the rise.
Thank you for the kind words, and I would like to start with the second question. We don't know exactly the exact incidence of Trichomonas in Hungary, but possibly it's quite low. So mostly, and in many cases, it's under-detected because at 50% of cases, it's symptomless. To respond to the second question, we did it basically because there was no good or there was no good clinical there was not a good meta-analysis with bacterial vaginosis. So with Trichomonas vaginalis infection, there is no we didn't have any knowledge about the relationship between Trichomonas and HPV and cervical dysplasias.
Okay. Another question is related to your mission to change the Hungarian screening program. So how do you want to do this, and what category of women do you target?
Yeah, basically, I think it's advisable for the age 30 years group to change to, so now in Hungary we screen with cytology, but in the 30 years age group and above it would be more reasonable to screen with HPV-based detection, because this method is more sensitive and more reliable for cervical cancer screening.
Okay, thank you. The second aim of your PhD thesis was focused on the safety and efficacy of using imiquimod in the treatment of CIN lesions and HPV clearance compared to conservative surgical treatment, which is the gold standard. I saw the information concerning doses for vaginal application of imiquimod that you are presenting in one table, table S2. What can you say about the conditioning form, the frequency of application, the duration of the treatment?
This is a very good question because it varied in many studies. I think the optimal dose is 12 milligram. This is a suppository of imiquimod. And the question is how often should this patient use it? Because if more often we use it, we can see many side effects such as flu-like symptoms, myalgia. So in my opinion, so there is no consensus or knowledge about this, but the optimal dose would be around 12 milligrams once a weekly, maximum twice weekly. Okay?
Okay, thank you.
Sorry.
I appreciate also that you presented the side effects, and I agree with your conclusions. Imiquimod is safe and effective in reducing CIN and facilitating HPV clearance. While imiquimod is not a substitute for cone biopsy, it can be a valuable option for the treatment of high-grade cervical dysplasias. Can you be more precise? So it was applied also for CIN2 or also for CIN3?
So yes,
also for young women, also for old women, the results are different?
So all patients were CIN2 to 3 when we looked for the regression rate for CIN patients. So these women were in a cervical precancerous state. And usually the average age of this woman were around 34, 36 years. So where cervical dysplasias are the most common.
And additionally, imiquimod could also be considered for the management of low-grade cervical dysplasia. Do you have comparisons between follow-up and imiquimod usage for low-grade?
Yeah, thank you very much. I understand your question. We don't have data about low-grade CIN and topical imiquimod, but we could see that imiquimod was the most usable in studies where CIN2 was the most prevalent. And we know that CIN2 is different from CIN3, that it's a little bit different. And in those studies where the CIN2 and CIN3 ratio was the highest, those patients responded the better for imiquimod.
Also, I would suggest here that imiquimod is an even more interesting option for cervical lesions prolonged on the vagina. For vaginal lesions, we have only 2 therapeutic options, laser, CO2 laser vaporization or imiquimod. And unfortunately, laser is too expensive and requires special training, so imiquimod for this kind of lesions become the first option for many clinicians.
Unfortunately, imiquimod is quite pricey as well, so it's...
but if it is
if the social security pays the treatment, it's better for the patient. So this is also a selection criteria to give this drug, because it's there's off-label use of this drug already.
Thank you. I also noted the recommendation for the chapter on future perspectives. Personalized treatment with imiquimod is promising, as prior immunohistological examination can predict therapeutic response, given that not all patients respond to imiquimod. So you are looking for a biomarker to select people who will respond to imiquimod.
No, I will explain it. Can this work again? Perfect. So we are moving back to this study, the Hendricks study. They did a post hoc analysis, and they analyzed patients' conizations, and they did there was no special immunohistochemical marker. What they did, they looked for immunological reactiveness. Okay, so how many CD8? So it was well established in the articles, and they found that based on the immunohistological compartment, they can predict who will respond to imiquimod and who will not. And actually, this analysis showed that women who had a high immune microenvironment responded to imiquimod, and they experienced regression to scene 1 or to scene 0. So basically, we can give prior we start the therapy, we can do a punch biopsy, we can have this immunological reaction, and we can tell to the hopefully we can tell to the patient to engage with imiquimod or not, based on the immunological microenvironment, and the negative predictive value and the positive predictive value was over 90%. So they could tell it very precisely.
So thank you. Actually, I'm sorry that I put so many questions, but the subject is of utmost interest for me.
I know, yes.
So I congratulate
Thank you very much.
for the two study research, and because you published in so well-quoted journals.
Thank you very much for your questions and your interest.
Thank you very much, and congratulations on your work and both of your papers. They are absolutely outstanding. And about the evaluation of Dr. Balázs Hamar, I would not read it. I would just like to state that the second work about the imiquimod was the first meta-analysis in the subject in the literature, and about the first one, it was really decades since there was a meta-analysis, so there was a lot of new scientific data that was concluded in the first work as well. And there are specific new findings of the thesis, which I will not read again, and I would just like to ask my questions. And the first one is, how do you explain that trichomonas infected South American women, you did not speak in the lecture,
yes,
but it was in your thesis, had 9 times more likely chance for low-grade SIL compared to the general population?
Because of very various sexual habits, basically. So, and in low economical states, trichomonas is quite common because of this reason.
So it's because of the more common infection of the
because of the
co-infections besides trichomonas as well?
Yes,
or?
but I think mostly because of sexual habits, basically, and the sexual behaviors. That would be my answer.
That's a good guess compared to other cancers in South America, and that's a good answer. All right. Although it is not on the outer cervix, but from your study came that Trichomonas vaginalis infection did not have any increase on the atypical glandular cells. So in your yes, meta-analysis, yes, Trichomonas infection did not have any increase on the atypical glandular cells.
No,
of
not
the
exactly.
cervix.
We were exclusively looking for epithelial cells, so we didn't look for anything.
But I think you did have data on the agus as well.
Yeah, sorry, I don't understand.
Atypical glandular cells.
Yes, we had 2 studies for EGC, and statistically there was no significant finding. So no, we didn't find any. So there was no.
Do you think it was only statistically, or it doesn't cause cervicitis?
I think it was only statistically. So if you would look at the patients with this, so I think because of the general inflammation, and AGC,
we should have seen that.
Sometimes it's just because of inflammation in better scenarios. So yes, it can be, yes.
Yeah, but to my opinion, that's because that's much less frequent than atypical squamous infections. So probably the statistical significance was not there. Okay, was there? You said it was a cross-sectional study. Exactly. So Trichomonas infected women had higher chance for concomitant cervical cancer.
Yes.
What was the time frame, or was there any time frame, or was it different in the different studies?
This was a big limitation of our study, that these studies were mostly, or no, they were like all cross-sectional studies, so it's just cross-sectional pictures, and this is the reason why we cannot say that Trichomonas infection is a risk factor. We can say there is an association, but because we don't have longitudinal studies to establish this relationship, we can only say that there is an association between Trichomonas and HPV and cervical lesions, and we looked forward to say it properly in the articles as well.
Do you have any information on the literature that what happens if a Trichomonas infected woman has treatment and effective treatment for Trichomonas, and what's the risk for the post Trichomonas treatment? So if someone's infected with TB and gets the treatment and becomes TB negative, but HPV positive, or
actually we don't. That would be a next clinical question and the future study, but. It's a good clinical question that we don't have answer for it yet.
Okay. What would no? You will ask it. I will not ask it. And you mentioned that in the discussion that chlamydia, bacterial vaginosis was also. Had also association with cervical cancer according to previous meta-analysis, and which one is stronger? What do you think, chlamydia, bacterial vaginosis, or Trichomonas in the association with cervical cancer?
Both three of microorganisms showed association with HPV and cervical lesions. If I remember correctly, the highest was with chlamydia, so the odds ratio around 3. So that was the highest association between cervical lesions and chlamydia. BV was around the same as Trichomonas in our study.
Thank you very much.
I have only one short question, but perhaps you already told us, but I didn't catch it. Yes. So you mentioned that we should give twice a week, 1 or twice a week, this imiquimod, but how long should we prescribe it? Yeah,
exactly. That's a very important question, the duration of the usage. Usually this also differed in the studies. Most commonly it was applied for 12 weeks. So we have information, I think, in 6 studies that used it for 12 weeks, and that was the general approach.
Thank you.
So thank you very much for the presentation, and then we have a short assembly, and then we will come back again.
Thank you very much for the audience.
Thank you very much for your presentation. We were all agreed on that this was a really elegant presentation, an elegant discussion. The topic is really important, so it has a high clinical relevance. There's not, as any of the opponents emphasized, that there is not a lot of knowledge about that, so it's really groundbreaking, and we hope that you will have a nice and bright future before you, also as a scientist, as a clinical scientist, and as a gynecologist as well. So your result or end result is 100%. Everybody was very satisfied with your results and all the things. So congratulations to you. And just if I can, I don't know whether okay, just have a sit down. Congratulations to you.
Thank you very much for the kind words.
Actually, I don't know. I don't see Professor Hegyi. He might have to go away, but I just want to say some kind of closing remarks, because this was my first time to be here at the Translational Medicine program, and I think I am really impressed. I'm really impressed the knowledge that you have. I'm really impressed how prepared you are. I took part a lot of, let us say, normal PhD defenses during the years, and the way of your debating, the questions and answers, and how prepared you are. It's really impressive. It's encouraging. I hope that this program will grow on and on. I really hope that even more clinicians will admit, from our age, will admit the importance of this program. So thank you very much for all you attending here. On the other hand, it's also really impressive and surprising. We are accustomed to that after 2 lectures, everybody is going away. So it's almost 5 o'clock. You are sitting here for a day and everybody is here. So thank you very much for your attention, for your active participation, for the tutors, the mentors, everybody. And although he is not here, I think that we can... Yes, let's you. I just don't want to say that from my side. I'm really grateful for Professor Hegyi and also for you and all those ones who are helping this today program, the secretaries, the statisticians, so everybody. That was my
Yeah, as most of you probably already know, that if Peter Hegyi is not there somewhere, then I have to show up, actually, for replacing him. And that is not easy, I have to say. If somebody wants to say here, the final words. Actually, there's quite a few people who could do this. So, I will not repeat what you said. Citi, I'm also kind of, love these presentations. And then we very much like the presentations and discussions. And even the bitter parts, I like, because I think that is also a part of scientific discussion, that you have to reply to very unexpected and very kind of different kind of approaches. So that is important. We can have a debate on that anyway. But you all made it quite fine. All the fellows did quite fine. And then they were prepared actually by the supervisor, by the SMSs, by the statisticians, by the WHO staff. And then this also shows, just confirms that we together are much stronger than the individual persons. Not patients too, that's another. Anyway, so, but at the end, we have to thank to the committee, especially Andrea Fekete, because she served as a chairperson in four PhD defense. The only thing that we will invite you to complex exam. That's much easier because there are 16 to 18 people, you see, and that starts at 8 and then goes up to around 7:30 or so, and then you will see, and that is also a tough job. But that is also rewarding because we all, only the committee, and then everybody who attends actively on this, learn a lot. And also, we learn not only kind of informations, but we also learn cooperativity. And this is one of the biggest strengths of this program, besides science to healthcare. That's important too, but you can work together. And we can work together with the tutors, with the leaders of the university, but also everybody actually who is in the system. So I could just congratulate and invite you to some more sandwiches, and also we have a little bit of wine actually outside, actually set by Peter Hegyi's taste. It's pretty good, so I highly recommend that you have a little bit. And again, thank you very much for all the achievements and attendance and patience and activity today. Okay, thank you very much.